Good morning to all. I am Dr. Subbiah. Today I am going to discuss about white hemithorax in children. The term white hemithorax is used to describe a radio-opaque hemithorax at chest X-ray, usually homogeneous in density but sometimes with scattered areas of air or calcium. So knowledge of the patient's age and clinical symptoms and recognition of the position of the mediastinal structures are essential to establish a complete differential diagnosis and subsequently for reaching the correct diagnosis. So for educational purposes, the white hemithorax has been divided into two groups according to the age and position of the mediastinum. So white hemithorax in the neonate with ipsilateral mediastinal displacement with contralateral mediastinal displacement. And white hemithorax beyond the neonatal period with ipsilateral mediastinal displacement and with contralateral mediastinal displacement. Now first we are going to see about the white hemithorax in the neonate with ipsilateral mediastinal displacement. So lung agenesis, lung hypoplasia and lung collapse are the most common causes of white hemithorax with volume loss in the neonate. So invalid hemithorax will be homogeneously white. Recent extubation and malpositioned endotracheal tube are common causes of unilateral lung atelectasis in neonates. So this is a 23-day-old preterm infant with right atelectasis which simulates lung agenesis. The child had recently been extubated and developed respiratory distress. The condition resolved following physiotherapy. So repeat radiograph following physiotherapy is normal. So white hemithorax in the neonate with contralateral mediastinal displacement. Here pleural effusion and volume occupying congenital malformations are common causes. So pleural effusion in the neonate is almost always chylous and volume occupying congenital malformations such as congenital diaphragmatic hernia, cystic adenomatoid malformation and pulmonary sequestrations are common causes of white hemithorax with contralateral mediastinal displacement in neonates. However, in these cases, the density of the involved hemithorax will be usually heterogeneous. So this is a chest X-ray of a neonate which shows a large amount of right pleural fluid with contralateral mediastinal displacement. Here pleural tap yielded a large amount of chylous fluid. This is another newborn who presented with respiratory distress. Ultrasound demonstrated a left pleural effusion and a large echogenic supradiaphragmatic mass. Chest CT confirms the presence of the supradiaphragmatic mass and its aortic supply. The final diagnosis was extralobar sequestration. So now coming to the causes of white hemithorax beyond the neonatal period with ipsilateral mediastinal displacement. So here also lung agenesis, lung hypoplasia and lung collapse are common causes. Lung agenesis and hypoplasia cause less symptoms, whereas lung collapse produces severe respiratory symptoms regardless of etiology. The differential diagnosis of lung collapse are foreign body aspiration, bronchial mucus plugs, endobronchial tumors, and extrinsic bronchial compression. So most patients with mucus plugs have a history of bronchial asthma. So 2-year-old boy presented with dyspnea. So chest X-ray showed whiteout of the left lung with ipsilateral mediastinal shift, and CT chest showed total atelectasis of the left lung, and a white mucus plug was found in the left mainstem bronchus on bronchoscopy. Diagnosis was bronchial mucus cast. With another 10-month-old girl presented with few episodes of bronchitis. Chest X-ray showed a white right hemithorax with ipsilateral mediastinal shift. Final diagnosis in this patient was right pulmonary agenesis, which was confirmed with chest CT. A 10-year-old boy presented with severe cough. The left lung is decreased in size and mediastinum shifted to the left. The air-filled left main bronchus is interrupted abruptly. The right lung is over-aerated and is herniated to the left. So at bronchoscopy, a peanut was removed from the left main bronchus. Another child, 3-year-old child, presented with severe cough of sudden onset. Chest X-ray showed an opaque left lung with interrupted main bronchus and associated left pneumomediastinum. So these two later findings are characteristic features of bronchial obstruction. At bronchoscopy, a sunflower seed was removed from the left main bronchus. So CT and MRI are the diagnostic techniques of choice when dealing with unexplained unilateral atelectasis or when extrinsic bronchial compression by a tumor, enlarged lymph nodes or abnormal vascular structures are suspected. So causes of white hemithorax beyond the neonatal period with contralateral mediastinal displacement. So the causes could be isolated pleural effusion, congenital malformations when they are secondarily infected, pneumonia with the pleural effusion, tumor and some vascular lesions. Here is a 2-year-old girl presented with fever and dyspnea. The diagnosis was pneumococcal pneumonia with the pleural effusion. The 1-year-old child presented with fever and breathlessness. Chest X-ray showed whiteout left lung with the contralateral mediastinal position. The chest CT demonstrated large pleural effusion surrounding the collapsed left lung. So the diagnosed chest ultrasound has replaced contrast enhanced chest CT in the assessment of children with pneumonia. However, CT or MRI is required when ultrasound reveals features suggestive of tumor, malformation or vascular disorders. Here is another child presented with cough, fever and mild tachypnea. And the chest CT confirmed a presence of solid mass with some costal erosion. So the final diagnosis was Ewing's sarcoma, Ewing's tumor. The 2-year-old previously healthy boy presented with a week-long history of mild cough and wheeze followed by rapid progression to severe dyspnea. Chest X-ray showed whiteout left lung with contralateral mediastinal shift. A nasogastric tube and a tracheal tube deviated to the right side. Bronchoscopic view showed a extrabronchial compression of the left main bronchus. So enhanced chest CT scan demonstrated a large homogeneous tumor in the anterior mediastinum. So lymphomas and teratomas are the most common anterior mediastinal tumors. A 5-year-old boy presented with fever of 3 months duration. And chest X-ray shows a enlarged white left hemithorax and a curvilinear interface crossing the low dorsal spine. And chest ultrasound and Doppler shows a small pleural effusion and a vascular lesion. MRI confirms the presence of a large aortic aneurysm. The final diagnosis was Takayasu arteritis. This 11-year-old boy presented with progressive dyspnea over several months. And chest X-ray shows a left hemithorax, white left hemithorax with some calcifications in the right side. The contrast enhanced CT shows a large heterogeneous mass with cystic spaces, fat and calcifications. A mediastinal mature teratoma was confirmed at surgery. A 2-year-old boy presented with fever, respiratory distress and chest X-ray showed a large homogeneously white left hemithorax. And CT revealed a huge pleural effusion, a solid multi-lobulated partially calcified left chest mass which invades the extradural space. So final diagnosis was neuroblastoma. 2-year-old child presented with respiratory distress. and chest X-ray showed a large homogeneously white right hemithorax. The right clavicle has some osteoporotic changes like permeative pattern of abnormality. So repeat chest X-ray after a pleural tap of 300 ml chylous fluid better demonstrated the abnormality of the right clavicle and significant thinning of the second right rib also seen. So the diagnosis was Gorham disease. So Gorham disease or vanishing bone disease is a poorly understood rare skeletal condition which manifests with massive progressive osteolysis along with proliferation of thin-walled vascular channels. A 5-year-old boy presented with fever, cough and decreased breath sounds on the right side. And CT confirms the presence of a huge right-sided chest mass displacing the mediastinal structures. So several areas within the mass did not enhance following the administration of intravenous contrast material. So the final diagnosis was thoracic rhabdoid tumor originating from the soft tissues of the inner aspect of the posterior chest wall. So summary, the white hemithorax is a common finding on chest radiographs in children and it may be due to variety of chest disorders. In most cases, plain chest X-ray and ultrasound are enough. However, additional information provided by CT or MRI is sometimes required. So these are the references. Thank you.